So, Ms. Bigham, what did the behavioral health landscape look like before Georgia began building out the system of care?
When I started working with what's now behavioral health in 1984, we basically had outpatient assessment and therapy through what were then called the mental health, mental retardation area programs. And there were probably about 27, 28 of those. Each of those had a designated person for child and adolescent mental health, but it didn't mean they were a specialist in children's services. In the larger area programs they were, in the smaller it was just somebody who wore many hats. Then there was also public hospitalization at the mental health hospitals. There were 8 at that time, and they each had a unit for children and adolescents. We tried not to hospitalize young children as little as possible, but there were, I don't actually remember how many beds there were, but those were the only hospitalization beds in the state. There was no under 21 Medicaid option that would pay for private hospitalization. Then there was residential treatment, and that was very limited. There were 2 outdoor therapeutic programs, one in Warm Springs, Georgia, and one in Cleveland, up in the northeast part of the state. And then there were private programs that were considered residential treatment that were a step down from hospitalization, but they were still somewhat institutional. Places like Laurel Heights and Devereaux, just as examples. And there were a handful or less of group homes, what at that time was known as the Charlie program. It became Chris Kids. So basically outpatient assessment and treatment, hospitalization, residential treatment through the private sector.
And what were the precursors to system of care in Georgia?
I would say that the main precursor was the federal CASP grant, the Child and Adolescent Service System program, and I was hired as part of that grant when I began in 1984. In the state, what is now behavioral health offices, there were 2 people who managed the planning and setting up of any children's services in the state of Georgia. And they wrote a grant, and Georgia was one of the first 10 states to receive a CASP grant. With that grant, in 1984, 4 people were hired, and I was one of those. Priscilla Cassiolini, who is now retired, was the director of the program, and I was hired as the consultant for the northern part of Georgia. Then there was one for central Georgia and one for south Georgia.
Okay. Can you discuss any of the other early funding for system of care, such as a K-SIG grant or any other funding that may have helped develop the system?
There really wasn't any other funding at that time in the 80s. What we did have was the Troubled Children's Committees. The Troubled Children's Committees later became the Match Committees, and they were still called that when I left. I think they have a different name now. Yeah. But they were the local interagency committees that had representatives from education, behavioral health, the Department of Juvenile Justice, which at that time was part of the Department of Human Resources. It didn't become its own separate agency until 1992. Other people who were involved were, of course, DFACS and other local representatives in the local areas. There were 7 of those local committees when I began, primarily in the larger cities or counties like DeKalb County, Fulton County, Chatham County, and a handful of others. One of the first things we were supposed to do with the CASP grant was help get those kinds of local interagency committees started all over the state. So that's why we were divided up into the 3 sections of the state. I covered North Georgia, and then someone covered Central Georgia, Macon, and East-West, and then we had someone situated in Savannah who handled South Georgia. And it was our job to help really market the idea of those, what were then called local troubled children's committees. And there was a fund through the Department of Human Resources, and there was funding through the Department of Education that could be used to pay for children who were considered the most troubled in the state to get funding for residential treatment.
Okay. So you've spoken about some of the funding that helped develop the system of care in addition to some of the teams that developed as a result of that funding. Can you discuss the legislative process for helping to create that infrastructure?
For creating the infrastructure for the local interagency committees, the legislation was put forth by a representative from South Georgia who worked with our Savannah-based CASP representative, Steve Tanner. And the legislator put together a piece of legislation that required local communities to have local multi-agency teams or troubled children's committees. So that helped in what we were trying to do in terms of marketing the expansion of interagency collaboration for kids.
Okay. And I know you said a big part of you all's roles were split into the different regions of Georgia.
Mm-hmm.
Can you speak more about what that role was and how you helped to develop those teams and get people on board?
We did a lot of traveling, but it was mostly day trips because we were within a day's drive of the areas we were covering. So I drove all over North Georgia, basically from I-20 up, every little local community. And I would contact people from, sometimes it would be DFACS, sometimes it would be mental health, or the Department of Juvenile Justice that was part of DHR then, and try to get a meeting together of the appropriate people, and I would go meet with them and talk about the committees that existed in some of the bigger areas and what they did and how that was able to provide a better system of care for kids than we had with everybody operating in a silo. And sometimes at cross purposes, with one agency clamoring for residential treatment and another agency trying to keep the child at home. So there were a lot of barriers because of attitudes as well as lack of funding.
Okay. We actually started answering my next question. What were some of the challenges you faced in the early period of children's behavioral health work?
Well, some of those attitudes that were problematic were that most children didn't have mental health issues, and that's true, most don't. But I don't think I think very few people really understood the breadth of the issue and what a large percentage of kids really do have mental health issues. And when I say large percentage, it doesn't have to be 50% to be large. It can be 15%, And in a state as large as Georgia, that's a lot of children and adolescents. So that was one. I think there was a lack of understanding of what could be done in terms of community-based care. People knew outpatient therapy, they knew hospitalization on a locked ward, and they knew residential treatment in places that were somewhat institutional but not locked. And that was all they knew. They had not heard of other types of services, weren't aware of them. So we did a lot of marketing of the different levels of treatment within a system of care to try to get people on board with helping us advocate for community-based services like day treatment. There was day treatment for adults, but nobody had ever heard of day treatment for kids. And things like therapeutic foster care in the community, therapeutic group homes, crisis teams, all of those types of things just weren't on people's radar in the 80s.
So to make that transition from, I guess, this concept or mindset of institutionalizing kids, were you all looking at what other states were doing, or
Yes.
different type of research?
Part of being one of the 10 states that was the first recipient of a Child and Adolescent Service System Program grant was the fact that we got to meet with other states and meet with the feds who had information about what states that didn't even have CAS grants might be doing. So we traveled to a conference about once every 6 months for education and training purposes, as well as for networking with the other states that had grants and some of the other states that were considered more forward-thinking in terms of children's mental health services. So we found that federal component very helpful.
So how did unbundling of services affect the service array and delivery in Georgia?
Well, actually, you're talking about something that came after my time.
Okay.
So instead of talking about unbundling, let me talk a little bit about how we got funding for local system of care services in the state. After our first charge to help generate more local collaboration for kids from all the child serving agencies, setting up those local multi-agency committees, the next thing we started working on was trying to get funding for day treatment, therapeutic foster care, in-home services, group homes, and other types of local services, so that it wasn't just outpatient therapy or nothing, or you had to go somewhere else. And we did that by creating categories of services and descriptions of those services, staffing patterns for those services, the number and the criteria for the type of background those staff would have, and then what it would cost to implement those services. We also did a needs assessment early on because there was no clear understanding across the state in what the local communities needed in terms of the types of service array. So we contracted early on with funding through DHR, through behavioral health, to have a needs assessment for kids done. And we hired an outside consultant, but who was based in Atlanta and had worked in mental health services herself. And she helped us put together a survey instrument to go out to all of the child and adolescent mental health coordinators in the state with question about what they saw as the needs in their area program, which we considered their community. For example, Gwinnett Newton Rockdale was one area program, and so that would have been a needs assessment for those 3 counties. And the needs assessment gave the descriptions of the types of services that we were asking about and asked them how many kids they had in their current outpatient enrollment that they thought would benefit from those types of services. We also did some population studies about just what the population was and what the federal SAMHSA at that time said in terms of the number or percentage of children in the general population. And when I say children, I mean children and adolescents. And we considered that kids up to 21 years old. For some things it was 18, but in general up to 21. And from the result of that needs assessment, then we put together a legislative budget request package that was divided into 2 phases, where we didn't ask for everything at once. We asked for about half of what a community needed because we felt like it would be easier to implement half at a time rather than to just be flooded with all these things you had to start at once. And another thing that we did differently than had ever been done before, instead of asking for a group home for this area and therapeutic foster care for another area and an in-home crisis team for another place, so that it was a scattershot approach, which is the way we had always asked for things before. And up until 1989, we got 0 for our requests through that scattershot approach. And we decided, okay, we're going to focus on one area program and say, this is what this area program needs for phase 1. And we want more outpatient therapists, we want day treatment, we want therapeutic foster care, we want in-home crisis teams, we want group homes, we want the whole thing. We just want the amount that's needed for half the population. And so we had one area that we were targeting on. And that was the Richmond service area. Richmond, that is Augusta plus a number of other counties. And we were successful in getting $450,000 funded in fiscal year '89 for Richmond's mental health center to start implementing some of those services. And then the next year we asked for DeKalb County, and we got some of that. And I don't think we got anything in '91 because we had gone through a recession, 90-91, and the legislature was paring back. There were rifts in state government, reductions in force. But in '92, we got a fair number of areas that got some funding. So basically from '89 to '99, that 10-year period, with the exception of '91, because of the recession, we got funding for phase 1 across the state. And that's about the time I left.
Okay.
So I know other things happened, like the unbundling of services and the under 21 option for hospitalization and those kinds of things, but even though I'm aware of it, I'm not up to date and don't really know all the ins and outs of it.
Okay. Well, that was